Okay, well, to be mindful of everyone's time, I think we will go ahead and get started. There's a few things to discuss before we jump into the presentation. Thank you for joining us today. My name, for those of you who don't know me, I am Amanda Tavalda. I'm the Communications and Fundraising Coordinator for Hospice Aurelia here in Aurelia in Ontario. And I'm very excited to have you all here today for our final session of our Tools in Your Toolbox series. Today, we'll be discussing the Clinical Frailty Scale. Before we begin with that, I would like to acknowledge and recognize that we are situated on Aboriginal land that has been inhabited by Indigenous peoples from the beginning. As settlers, we're grateful for the opportunity to meet here, and we thank all generations of people who have taken care of this land for thousands of years. In particular, we acknowledge that this is the traditional land and territory of the Anishinaabe people, specifically Ojibwe and Chippewa people. We recognize and deeply appreciate their historic connection to this land. We also recognize the contributions of Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community in particular, and our province and country as a whole. We are committed to moving forward in a spirit of reconciliation and respect. In addition, the North Simcoe Muskoka Hospice Palliative Care Network would also like to take this opportunity to acknowledge the hard work and dedication that the frontline healthcare workers have displayed during this pandemic, as well as the burnout that many are experiencing. Each and every one of you have helped to uphold our healthcare system and will lead the way while we move to recovering from this pandemic. Your selflessness and dedication have not gone unnoticed. Thank you so much. And now I would like to go ahead and introduce or say thank you actually to our who's made this financially possible, which is Health Canada. So it wouldn't be without their support that we wouldn't be here today. So thank you so much to Health Canada for their financial contributions. And now I will introduce our guest speakers. We will be meeting with Charlene Hagerman and Sue Martin. Ladies, I will turn the floor over to you.
Hello, my name is Charlene Hagerman. I am a nurse consultant with the North Simcoe Muskoka Hospice Palliative Care Network, and I've been working with the network for the last 11 years. It's my privilege to be sharing some information today on the Clinical Frailty Scale with my colleague Sue.
Hello, I'm Sue Martin. I'm a registered nurse, and I've been working with North Simcoe Muskoka Hospice Palliative Care Network for about 9 years. Charlene and I are really happy to have you join us today. We would ask that if you don't mind entering into the chat what your role is and where you are located, just so we have an idea of what the representation is. So just take a minute to do that if you don't mind. Our learning objectives today are listed here. By the end of the session, we hope that you'll be able to define and discuss frailty, implement the Clinical Frailty Scale, understand the clinical significance of using the Clinical Frailty Scale, and we will be referring to the Clinical Frailty Scale as CFS. We're going to share some information with you about CFS. Then we'll have a few case studies. We do encourage questions or comments and ask that they be posed in the chat box. In this ECHO series, we've had previous presentations on the surprise question, the PPS, the ESAS, and today we're happy to be reviewing the Clinical Frailty Scale, which is another valuable tool in palliative care. Now, Charlene is going to talk to you a little bit about the background of the Clinical Frailty Scale.
So the Clinical Frailty Scale was developed in Halifax, Nova Scotia in the 1900s by Dr. Kenneth Rockwood. Several articles cite the year 2005 as the year the Frailty Scale became a validated tool. It was designed initially as a 7-point scale in 2007 and later modified to a 9-point scale to include the severely frail and terminally ill. The latest revision was done in 2020 and it's titled the CFS version 2.0. The scale was originally intended to be used as geriatricians as part of a comprehensive geriatric assessment of their patients. There were minor clarifying edits to the level descriptions that included Level 2 was changed from well to fit. Level 4 changed from vulnerable to living with mild frailty. Level 5 to 8 changed from mild, moderate, and severe and very severe frailty to living with mild frailty, moderate frailty, severe frailty, and very severe frailty. The CFS is used in over 20 countries worldwide, and it's considered a validated screening tool to assist in making important clinical decisions. So this is just a visual of the most recent 2.0 version of the Clinical Frailty Scale. So what is frailty? Frailty is a state of increased risk and vulnerability to stressors due to age, disease, and deficits that accumulate across multiple domains. There's no single accepted definition of frailty, and frailty is a medical condition of reduced function and health in older individuals. It's often associated with low energy, slow walking speed, poor strength, and weight loss. It's not synonymous with getting old. And deficits can accumulate and present challenges. It's when many things go wrong at once. It does impact higher order functioning, how one is able to look after themselves, their physical needs, their financial needs, and how they interact with others and move about safely and think and do as they please. Frailty is the difference between biological age and chronological age. Frailty is more centered around biological age. Chronological age is the number of years that has passed since you were born. Biological age is dependent on numerous variables that are changeable. These are physiological or functional age. A quarter of people over the age of 65 have some degree of frailty. Factors that can alter the degree of frailty include genetics, lifestyle, nutrition, and diseases. It's a risk compared to others of same age. We can see a fit, active 90-year-old with a low frailty score and an inactive 65-year-old with a high frailty score. Getting older doesn't necessarily mean someone is frail, but it does increase the odds of developing multiple conditions and frailty. Things like inactivity, poor nutrition, and social isolation or loneliness, and multiple medications can all contribute to frailty. When you are frail, your body does not have the ability to cope with minor illnesses that would normally have minimal impact if you are healthy. With frailty, these minor stressors may trigger rapid and dramatic deterioration. For most, similar to the risk of dying, the risk of frailty increases with age.
Before we go any further, I did want to make note that Charlene and I are sitting quite close together, but only because we've been really careful. We did do a rapid test before joining you today. So we are taking precautions, and I hope everybody else has been taking the proper precautions and are safe out there. So we're going to talk about implementing the frailty scale. After assessment of the patient, a trained individual can grade the degree of frailty. A trained individual can include, for example, a physician or a nurse or an OT or a physio. There are 9 degrees or levels of frailty, which are based on clinical evaluation in the domains of mobility, energy, physical activity, and function. It's quick and easy to use, but taking a proper history is essential. Scoring using the CFS is based on the patient's premorbid status, not in the moment. It's suggested to apply the score on a person's baseline health status 2 weeks prior to the current event. CFS is designed for people over the age of 65. It's not designed for those who have a stable single system disability, such as a spinal cord injury or a developmental delay. Factors to consider: the patient may be confused or forgetful due to cognitive impairment or have an altered level of consciousness. If the patient can't provide you with all of the required information, involve someone who knows them well. Trust what the person's telling you, but verify the information. It's about finding out the person's baseline. The more information you have to guide you, the better. Ask the family member how they feel the patient is doing overall. For example, are they managing with their ADLs? Is support required? How are they doing with medication management? How functional or how active are they? But be aware that patients may be trying to cover up how they are doing for many different reasons. This requires you to use your judgment and expertise as a healthcare provider to consider what you hear and observe. Frailty is a clinical judgment that must be sensed, described, and measured, not guessed upon. The CFS can be used in people with dementia, and it's for people who are near to death. We look at their current status, not their previous baseline status. So some questions that you may consider using when you're inquiring about the person's ADLs. Ask if they shower independently. Are they getting dressed on their own? Maybe they have help coming into the home, or are family assisting? Ask about their mobility. How often do they walk, and how far do they go? What aids do they use? If they're not mobilizing well, why? Due to physical limitations or weakness or fatigue, or perhaps they have no interest. Ask if they're having pain. Is pain causing mobility issues? Is it related to a medical condition such as arthritis in the knees? And ask about participation in activities. Do you belong in any social clubs, fitness classes? Are you dancing? Do you play pickleball? Are you part of a walking club? And then ask about IADLs. They may need help with household chores such as vacuuming or managing finances. Do they need help paying bills or with the banking? Charlene's going to speak about scoring the CFS.
So in level 1, a person is very fit. People are robust, active, energetic, and motivated. They tend to exercise regularly and are among the fittest for their age. Level 2 is termed fit. It was previously termed well. People who have no active disease symptoms but are less fit than category 1. Often they exercise or are active occasionally, such as seasonally. In level 3 is managing well. People whose medical conditions are well controlled, even if occasionally symptomatic, but often they're not regularly active beyond routine walking. And for example, in level 3, someone might be on a medication such as an ACE inhibitor for symptom management of congestive heart failure, but their symptoms are well controlled and do not limit activity at this time. So level 4 is living with very mild frailty. So it was previously termed vulnerable. This category marks early transition from complete independence. While not dependent on others for daily help, often symptoms do limit their activities. A common complaint is feeling slowed up or just being tired during the day. People in level 4 often have many chronic illnesses and uncontrolled symptoms. At this time, people report that their health prevents them from doing what they previously enjoyed and takes a lot more effort to perform these activities. They are most likely having difficulty with chores such as lifting, heavy housework, taking out the trash, climbing stairs. And often, as increased difficulty occurs, people tend not to do these activities or chores as well, and they may start relying on others to assist. When asked how they rate their health, often they do not say excellent or good at this time, but may say fair or poor. From levels 4 to 7, the key factors to consider with scoring are mobility, function, and cognition. It's a combination of impaired function and impaired mobility, along with common illnesses that will likely make someone frail. Level 5 is living with mild frailty, previously called mildly frail. People who often have more evidence of slowing and need help with higher order instrumental activities of daily living, their finances, transportation, heavy housework. Typically, mild frailty progressively impairs shopping and walking outside alone, meal preparation, medications, and begins to restrict even light housework. Patients at this level now cannot do activities that they were starting to struggle with in level 4, such as heavy housework or taking out the trash. They are not dependent in all strenuous activities. And it's at this time we're more interested in the changes that are starting to occur. So level 6 is living with moderate frailty, previously termed moderately frail. People who need help with all activities outside and with keeping house inside. They have problems with stairs and often need help with bathing and might need minimal assistance such as queuing or standby with getting dressed. But if someone has moderate dementia and moderate frailty, there's likely a need for additional assistance with bathing, including preparing the bath, assisting with taps and transfers in and out of the tub, and with washing one's hair. In level 7, living with severe frailty, it was previously termed severely frail. So in this level, they're completely dependent for personal care for whatever cause, and this cause could be physical or cognitive. Even so, they may seem stable and they're not often at risk of dying within 6 months. In this level, a person is still mobile, but may be spending more time in bed or sitting in a chair. And this is just another visual of the frailty scale. So we're moving on to level 8. So level 8 is living with very severe frailty, previously termed very severely frail. So completely dependent for personal care, and we're approaching end of life. Typically, they cannot even recover from even a minor illness. The person often spends most of their time in bed prior to dying, and this decline may have been precipitated by an identified episode such as an infection or an exacerbation of a chronic disease, such as congestive heart failure or COPD. The decline may be slow due to a decrease in oral intake, and often a person at this time does not have a lot of pain or distress, but there can be some exceptions. Level 9, terminally ill. At this time, a person is approaching end of life. This category applies to a person with life expectancy of less than 6 months, who are not otherwise living with severe frailty. Many terminally ill people can still exercise until very close to death. It's in this level, it's the current state that is what is considered, not the baseline state. The baseline state could fall into any of the frailty levels. The person on the visual scale you will note is pictured sitting in a chair, as it reflects the fact that many older adults who are dying of a single system illness, such as a cancer, may still have a reasonable amount of function until the very end. So within each level, individuals may vary, and 80% or more of the people will fit into a description offered for a given level. If they fit 2 categories equally well, it's best to score the higher or more dependent level. And this information was taken from the CFS guidance document version in April of 2020.
The degree of dementia usually corresponds to the degree of frailty. Mild dementia usually aligns with mild frailty. The person is likely independent with the basic ADLs, but dependent in one or more instrumental ADL. They may recall a recent event, but not the details of the event. They may be using cues to prevent losing items and may ask the same question over and over again in a short time frame. Moderate dementia aligns with moderate frailty. The person's recent memory is very impaired, but they often recall past life events quite well. Usually they can still do their own personal care with queuing or setup, but would need help with all outside activity and housekeeping. Severe dementia, as in severe frailty, people have progressive difficulty performing ADLs and require increasing amounts of hands-on assistance. So we're going to look at some case studies. We're going to incorporate what we've learned today into some case studies. And we'd really like your help in determining what you think the clinical frailty scale would be in each situation. So I encourage you to jot down a few key points as we review each case. So the first case is Mrs. Jones. She's 73 years old. She has an upcoming elective surgery for severe osteoarthritis of the knee. She lives alone in a 2-story home, and she uses a walker to mobilize. She's now had to hire someone to come in every 2 weeks to do housekeeping, vacuuming, clean the bathrooms. She's not able to do her gardening. She's becoming more forgetful and needs some help from her son with paying the bills and managing the finances. She still enjoys making meals and having family over to visit. Her medications are in a blister pack. So what do you think Mrs. Jones' CFS is, and what factors did you take into consideration to determine this? Amanda, can you help us with the chat box?
Absolutely.
Thank you.
So let's see, we'll get some notes here in a second, I'm sure.
Okay. Charlene's going to review it anyway.
Put up a visual of the CFS, which I believe is the next slide.
There we go. Yes. There it is.
So we don't have anything quite yet.
That's okay.
Oh, we have a 5 or a 6.
Oh.
And another 6.
Well, that's a good start.
Yep, and another 6. It seems to be the consensus across.
But okay,
the
so
group.
Charlene, perhaps you can help us out here.
Okay, well, actually, Mrs. Jones' clinical frailty score is a level 5. She's living with mild frailty. She's not totally, and some of the reasons that she's more in a level 5 than a level 6 is she's not totally dependent on others with daily assistance, but she is using a walker and a mobility aid. She is slowed up, and this is evidenced by her not able to do any gardening as she previously enjoyed. And she does have a chronic condition, which is her osteoarthritis of her knees that does limit her activity. And she is also showing signs of mild cognitive impairment.
Okay, thank you. So the next study is Lily. Lily is 81 years old, and she presents at the Emerge with a 2-day history of confusion, and she suffered a fall. She's independent with all her ADLs and IADLs, including banking and shopping. She has a history of mild CHF, but it's well controlled on medications. She still drives and goes out for a 15-minute walk without aids once a day in good weather. She attends a seniors fitness group once a week, as well as a local women's church group. On further investigation in the Emerge, they found that she has a bladder infection and mild dehydration. No injury was sustained from the fall, and the confusion cleared within 24 hours of antibiotic treatment. So again, what do you think Lily's CFS is, and what factors did you take into consideration to determine this? Charlene's going to help us out again.
We'll just give everybody a minute to see if you, and Sue, maybe you could just forward ahead and show a visual of the scale. So we'll give you a minute just to take a look at the scale and see if you could see where Lily would fit in this scale. Making you work. Any responses, Amanda?
There's not. Oh, we have a 2, 2, 3, and then a 4, and then another 2. They all kind of came in at once. Another 2.
So actually, the most
2, 3, 3
level for Lily is a 2, and the reason for this is we got to remember when we're scoring that we're looking at what Lily's baseline was. So this is kind of 2 weeks prior to the event that led her to the hospital. So she has no active disease. She does have some congestive heart failure, but well managed with medications. She does walk in good weather, so this would reinforce why she would fit into level 2 instead of level 1. So that's kind of a big difference for Lily, is the fact that she only walks in good weather. So that puts her in level 2. And remember, we're using her baseline health status, which was scoring her status a few weeks prior to her ending up in the ER.
And Laura says that she would say a level 2 because she recovered within 24 hours of treatment and then what she did before as well.
Exactly. Yeah.
Awesome. Great. So the next case is Tom. He's 63 years old with end-stage COPD. He lives alone and relies on PSWs twice a week to assist with the shower and he has a housekeeper once every 2 weeks to do housework and laundry. He has some mild cognitive impairment and relies on his brother for paying his bills and to do his grocery shopping. He does not drive. What would Tom's CFS be? And what factors did you take into consideration to determine this? So again, we'll wait a few.
Yeah, we'll give you just a minute. Do you need a visual of it again?
Yes, please. Thanks. Question here is, did you say previously that we can only use the CFS on those 65 and older?
Bingo. Yes, this is a little bit of a trick question thrown in, but whoever responded is absolutely right. The CFS is not appropriate for Tom because he's not 65, so we shouldn't even be using it.
Okay, very well done. So George, he's 79 years old. He's divorced. His 29-year-old grandson lives with him. He has moderate dementia with very poor recent memory, but good recollection of past life events. He has a history of coronary artery disease and he's had a triple bypass 2 years ago. He has type 2 diabetes and he receives PSW support 3 times a week and can do personal care with their prompting and setup assistance. He walks outside occasionally when accompanied using a walker. He lives in a 2-story home and has difficulty with stairs. So what do you think George's CFS would be?
Visual.
We have moderate dementia often corresponds with degree of frailty. So a 6, and then we've got another 6, another 6.
You guys are getting good. So yes, George is a level 6. He's living with moderate frailty. George requires care inside his home as well as outside. And other factors that would put him in a level 6 is he's doing stairs, but with difficulty still. He can still do basic ADLs, but needs prompting and cueing. And he does have several comorbidities, which is his coronary artery disease, diabetes, moderate dementia.
Okay, well done. So now we're going to address the clinical significance of using the Clinical Frailty Scale. Currently, there are over 1.6 million older Canadians living with frailty. This is projected to increase to over 2.5 million Canadians living with frailty in the next decade. Older, frail Canadians are higher users of our healthcare services. Our healthcare system is not designed well to meet the complex needs of many older adults. Coordinated care can be very difficult to achieve, often not meeting the needs of the patient, but governed by what policy says and what services are available. And access to care for the elderly can be very difficult. The CFS is used in many settings to guide decision-making. It can be used as a triage tool to make important clinical decisions. Use of the CFS can and should guide care plans. Care plans should vary by degree of frailty. For example, the ability to mobilize and climb stairs if living independently should be assessed prior to being discharged from the acute setting. The CFS is a great communication tool. It can bring together information in one place with one number. And it can assist in predicting outcomes and enable one to put proactive safety measures and supports in place. Charlene's going to speak to an article that she has.
Yeah, so we're going to talk about the use of the CFS during the COVID-19 pandemic. So there was an article published in March of 2021 by Deidre Taylor of the Nova Scotia Health Authority, and it was entitled Nova Scotia's Clinical Frailty Scale Used Worldwide when Making Decisions About Treating Frail Patients with COVID-19. It went on to say that during the height of the first wave of the pandemic, healthcare systems globally were put in a position of prioritizing access to critical care. Dr. Kenneth Rockwood was getting calls from all around the world as a number of countries began to refer to the CFS to help inform their decisions as to which patients should receive treatment in the ICUs. Keep in mind, the CFS was developed before COVID-19 and was originally intended to be used by geriatricians as part of a comprehensive geriatric assessment of their patients and to be used in the emergency room departments as a basis for screening, assessment, and guiding care plans. The intent of the CFS was not to prioritize access to life-saving measures in an ICU. Dr. Rockwood took a closer look at the clinical frailty levels and how they related to people with COVID-19. So many of the healthcare providers and administrators from around the world began adopting the scale and were identifying living with mild frailty, level 5, as the cutoff for whether a patient with COVID-19 should receive ICU treatment. Dr. Rockwood had recent data to support that level 5 was much too low, whether someone would have a good outcome. In a new study that Dr. Rockwood was about to publish, he had data from more than 1,000 older adults he had seen in the emergency department in Halifax that looked into a chance of patients dying within a 30-day period after experiencing an acute illness resulting in an emergency room visit. It showed most people living with mild frailty, which is level 5, or living with moderate frailty, level 6, could successfully be supported through an acute illness. Dr. Lisa Barrett, another researcher and infectious disease specialist at Nova Scotia Health, combined research with Dr. Rockwood and found that severely and very severely frail patients at level 7 or 8 were able to mount an immune response following exposure to the virus, which demonstrated that even with a higher frailty score, one's immune system can be robust. This information changed the discussion of rationing care in health systems experiencing crisis and led to Dr. Rockwood's ability to inform decision criteria that countries were having to put in place about providing and withholding treatment for frail patients with COVID-19. Dr. Rockwood saw an opportunity for further research and received funding from the Fountain Family Research Fund through the QE11 Foundation. This enabled him and a colleague, Dr. Olga Theo, to set up a study at 23 sites in 11 countries to validate an algorithm for healthcare providers who were not experts in frailty to effectively use the CFS. The research funding that we have received supports work that's having a global impact and puts Nova Scotia as a leader on the world stage, said Rockwood.
Interesting, eh?
Mm-hmm.
So prevention and treatment of frailty. Is frailty responsive to prevention and treatment? What do you think? Yes, absolutely. Factors to reduce the frailty risk include good nutrition, staying physically active, not too much alcohol, avoiding social isolation, staying engaged in local community, and reduce falls risk as much as possible. So that's easy, right? So keep that spring in your step by staying physically active, fill your plate with healthy food and limit alcohol, keep that optimistic feeling in your heart and stay socially connected, reduce fall risk as much as possible, and complete regular medication reviews. Avoid overprescribing and be aware of drug interactions and non-adherence. All of these factors and many more can contribute to reducing and delaying frailty and enable a healthy, more independent lifestyle as we age. Don't wait until you're 65 to take action. Here are some of the references that we've got listed here. And we just wanted to thank you for joining us today for the final session of the 4-part Tools in Your Toolbox series. Be sure to watch your inbox for the follow-up survey. Your feedback assists in assuring that we're meeting the needs of the hospice palliative care community. So this concludes our presentation on the Clinical Frailty Scale. And we're just wondering if there are any questions.
As of right now, there's a comment from Rachel saying, thank you for sharing the article and its summary. It's so relevant to our current state of healthcare, as well as she loves the moderation in all things is key, informative. Sorry, my screen moved, is key, not strict, rigid rules of avoidance.
Sure.
And Tracy is saying, thank you so much. This has been a very informative, great presentation.
Thank you.
Another thank you, and Tammy as well. Thank you. Love the case scenarios.
Good. That's great. Yeah, the article was really interesting.
Yeah.
And so
Oh, and there's another question. Sorry, ladies. Laura would like to know if there's somewhere that they can download the scale visual.
Yeah, there's also, you just have to really Google Clinical Frailty Scale and you'll come up with that. And just, take a close look though as to what version, because there is some of the older versions still out there.
We can
email it to you.
Yeah,
if you
yeah.
Yeah.
When we send out the follow-up email with the link to the recording as well as the survey, we will send out a link to the most up-to-date scale.
And there is a lot of information out there as to how to use the scale that has been developed by Dr. Kenneth Rockwood and his colleagues. So he designed this scale. So certainly the information for use with this scale is most relevant if it's come from an article that he's published. And there's even a hot tips 1-page sheet about using the Clinical Frailty Scale that's come out of Dalhousie University.
Great.
Excellent. Thank you so very much. We do have one more question.